When a woman's trying to get pregnant, we will check every hormone. There's like no stone left unturned. But if you take a woman who's the same age, let's just say she's 35 or 32, and she goes to her doctor and she's not trying to get pregnant, and she says, I'm exhausted. I don't have the energy that I used to have. I have all this belly fat accumulating, and I haven't changed what I'm eating. I'm still running, and yet I feel so depleted. What can we do? Can we check my hormones? That person is told, we don't check hormones. We think they fluctuate too much. It's not worth checking them. And that's what we need to change.
Welcome to the Betty Rocker Show, the place to be to nourish your mind, love your body, and rock your life. What's up, rock stars? Coach Betty Rocker here. Welcome back to the show. And I am so glad you're here today for this incredible conversation that I'm going to be having with Dr. Sara Gottfried. She's a women's hormone health specialist. She's a physician scientist who graduated from Harvard Medical School and MIT. She's the author of 3 New York Times best-selling books, including The Hormone Cure, The Hormone Reset Diet, and Younger. Look them up. Dr. Gottfried practices integrative, functional, and precision medicine in Berkeley, California, and she joins me today as we continue our conversation about the hormones and take a deep dive into understanding what's going on with them, how they shift and change over the course of our lives, common signs and symptoms you may have experienced or may experience at some point, and what to do about it. And I'm so glad you're here for this because as women, I just feel like we can be so empowered with this knowledge and we can be really greater advocates for our own health care. So join us for this powerful conversation. Dr. Sara Gottfried, welcome to the show. It's so wonderful to get a chance to connect in person. How are you today?
I'm so good. I'm happy to be talking to you. I feel like it's been a long time coming.
Right. And we've been having all these little back and forth conversations via DM and like in our email. And like we were saying just a minute ago, I feel like I know you from watching your amazing videos, and you so generously share so constantly about healthcare, helping all women, and you're just so sensitive to so many important topics and such a great educator. I absolutely love learning from you.
Well, thanks for that. I feel like we're girlfriends because we had brunch together when you did an IG Live recently.
That's so true. Good. Yes, we did. We had brunch together. And I shouted you out in that because, as you know, big fan of your work. And as a woman in my 40s at the time of this podcast recording, I've had great reason to seek out your knowledge, and I've read your books and have learned so much from them. It's really helped give me a deeper understanding of my own hormones, different things that happen throughout the life cycle. And we're going to get into a lot of that today in this show. But I was wondering, because as a woman, and I want to get to know you a little bit better as well. What initially got you interested in hormones and that, because that's a specialty aspect of medicine, of course. I'm just really curious.
Well, I would say the main thing that got me interested in hormones was that I was a hormonal hot mess in my mid-30s. And this was a number of different factors that came together that I think a lot of women will sort of nod their heads as they hear this. I had a couple of kids, never lost the weight after having babies, and I was working full time. And that combination alone, I think, is enough to trigger some of what I think of as the hormonal Charlie's Angels, which is cortisol, thyroid, and estrogen. And unfortunately, I went to my primary care provider and said, listen, I can't lose this baby fat, but in addition, I don't want to have sex with my husband. I have PMS. What do you have for me? Like, what solutions do you have? And he went through a series of 3 suggestions that just left me cold.
First, you said he. I like talking to a woman about woman stuff. I mean, Maybe I shouldn't, but I really do. And anyway, continue.
Well, I would hope
What
that
were these things he asked?
I would hope that it would be different with a female physician, but honestly, as someone who's gone through allopathic medical training, I'm not sure it would. So, what he said was, I think you should go on an antidepressant. He offered me a birth control pill because I think that's mainstream
The
medicine's
standard.
answer to every hormonal problem. And then he wrote on a whiteboard, this was the worst part, exercise more plus eat less.
No, he didn't.
Oh, yes, he did.
Oh no.
So
Oh
that
my.
that was the turning point for me because, at first I just had that flush of shame and humiliation that I think a lot of women experience. And then I realized, oh, this makes me angry. And it was that kind of righteous anger that I think can move mountains and start revolutions because I realized millions of women are being told exactly the same thing, and it is totally wrong. So that's what got me into this. That's what got me to pay attention to hormones. I left his office and went straight to the lab where I decided, okay, I'm going to apply what I know about the female body to myself and understand what's going on with my hormones.
You're just like a superhero, aren't you? Just like, yes, let me put on my cape and fly to the lab and I'm going to figure this out for us once and for all.
Well, Brie, I didn't feel like a superhero at that point. I mean, I felt like I was drinking too much. I was, stressing too much, and I just couldn't find my way out. I had belly fat, way more that would allow me to properly zip up my jeans, and I would say the cape didn't come for some years, but
Well, you made the cape yourself out of all of
I
this,
had
all
I
of
had to
this
make
work,
a
didn't
cape
you?
out of this. I mean, that's part of the composting experience, right? Like when you
Yeah.
are up against pain, when you're up against these challenges, the trick is to transmute it. Like, how do you turn it into gold? How do you turn it into something that can really support you so that your mess can become your message? And
Amazing.
yeah, I mean, the first thing that I found when I went to the lab was that my cortisol, the main stress hormone, was 3 times what it should have been. And, I found that this is actually incredibly common, especially for women in that age group of, I'd say 35 to 50, 55.
And that covers the spectrum of what we call perimenopause and menopause, correct?
It does, but I think it's important to realize, when I was 35, I thought perimenopause and menopause was like this cliff that was way off in the future that I didn't have to worry about. But the truth is, you start to have very subtle changes that can occur in your 30s. It can even start in your 20s. In my case, it was around 35. So there's these subtle changes as you start to run out of ripe eggs. You produce less progesterone, and then that can make your period a little closer together. It can make you moodier. So it can have all of these effects that you may or may not identify as perimenopause.
That makes complete sense. And this is why I hear from women all the time that write to me, how can I reset my hormones? I feel like something is off. And sometimes they're not aware that it is their hormones. And they're just asking me, look, I'm just over 40 and I have all this stubborn belly fat. My doctor says I'm just aging and I can't do anything about it. I want to do 3 of your challenges at the same time because clearly I need to exercise more and eat less. Exactly what your doctor told you. So I think these bad messages are being perpetuated, and it's why you have the superhero cape and you're educating us. Tell us more. Tell us more about the common hormone imbalances that you're describing and what the symptoms of them are.
Well, there's a lot of hormones to consider, and I like to try to make this as simple and fun as possible because the biochemistry of your endocrine system could torture you. So we have to have fun as we talk about this. And
You're so
I
awesome.
think that it can help to sort of personify these. And so, when it comes to the hormone imbalances that I see in women, there's 7 that I think are the most common. And I think we have to start with cortisol. It's not what a lot of people want to start with, but especially when you're talking about stubborn belly fat, what we know is that visceral fat is not just, an issue of vanity. It's biologically active. It secretes all of these messengers that can just wreak havoc and cause inflammation, unresolved chronic inflammation in the body. And so we need to address that. What are the hormones behind it? I would say cortisol, insulin. We could also talk about growth hormone, because those are the ones I think of when it comes to belly fat. So if we try to keep this as simple as possible, I would say high and low cortisol are the most common problem that I see. And what usually happens, my particular issue, is that I'm a cortisol junkie. So I'm pretty hard driven. I'm like a recovering type A personality. I'm like an A minus by now. And I know you know nothing about this in terms of driving yourself hard.
I was going to share a little bit too, but I want to hear more of your story first because I can so relate to what you're saying.
Well, I want to hear it, but what I found was that my cortisol was, as I said, triple what it should have been when I measured it first thing in the morning after leaving that doctor's office. And when your cortisol is that high, it has a number of effects. So what are the symptoms? It can make you feel tired but wired, kind of revved all the time, this uncomfortable feeling of rev. And what I'm trying to distinguish here is between good stress, also known as eustress, which is that positive stress that helps you, to jump out of bed in the morning and also can help you do well on a test. I happen to know you were like number 3 in your class in high school. So.
Oh, wow. You looked me up. Did your homework. It's true. I got a full academic scholarship to Tufts and was number 3 in my graduating class.
That is incredible. So, I know you know about this. And
yep.
So eustress is one thing. Toxic stress is yet another. And when you have this sense of chronic unremitting stress, it can lead to all of these costs in the body. So what does cortisol do? Its main job is to raise insulin. So it helps you with blood sugar management, and it helps you, fight, flight, freeze. So it helps you get out of a crisis. It helps you focus. It suppresses your immune system, but then long term, it can overactivate your immune system. So those are the main things that happen with cortisol.
I just feel like there's so many cases of people who don't realize that they have long-term chronic stress happening because there's a negative thought pattern that's happening where they're just beating themselves up constantly, not realizing that that's actually a long-term stressful event or pattern. And there's the sort of the unresolved trauma issue that can raise stress. That was one of my issues. I had a lot of early childhood trauma, sexual abuse, those types of things. And I was living with, I had grown up in a very heightened adrenaline state, just constantly being ready to deal with anything. So I grew up being an adrenaline junkie really because I was used to that kind of vibe and sought out a lot of adrenaline fueled things as a result. And my adrenals were tanked by the time I was in my early 30s, and my cortisol was always elevated. So it's been a something I'm always aware of, but until I was able to seek really good care for PTSD, I don't think I was able to help really reduce that unmitigated cortisol in my system, because I feel like trauma, we all deal with trauma, and we all deal with, we process it in different ways. I hadn't ever really processed it well. And that's something I think is really interesting with the cortisol equation as well, when we don't realize we've got this going on in our system for so long unmitigated, and we think, well, I'm not stressed, but we actually are. And so that's something that's just hard to pinpoint. It's hard to see the label from the inside of the jar, as it were.
Well, thank you for sharing that, because if you look at adverse childhood experiences, which are known as ACEs, we know that 2/3 of the US population was exposed to significant ACEs. My ACE score is 6. And we know that those experiences, whether it was abuse, physical, sexual, household dysfunction, such as divorce, or an alcoholic in the family, or a drug addict, any of these 10 different types of adverse childhood experiences that was studied starting 20 years ago, and now we've got like 96 studies on it. We know that leads to problems in middle age. And it can certainly lead to problems before middle age, as you were describing with your adrenal function. So I feel like this is in many ways the elephant in the room when it comes to cortisol, because so many of us have experienced trauma that in some ways we normalize it and we, sort of suppress it or stick it under the rug or, I've done enough therapy. I don't need to deal with that anymore. And yet this is the reason for higher rates of stroke. It's the reason for hormone imbalances. It is one of the most common disruptors of the control system for your hormones, which is the brain adrenal axis.
Yes.
So I think of this as the hypothalamic pituitary adrenal axis. You can think of it a little more broadly as we do in functional medicine and go out to hypothalamic pituitary adrenal thyroid gonadal gut axis. That's a total mouthful.
But I like how you're pointing to each part of the body where those glands are and where those parts of your body are. You're like, yep, hypothalamus, pituitary, kidney, adrenal, like, yep, you've got them all.
Yeah, well, it's important to realize that these all crosstalk. So it's not like you have this problem with cortisol and it's in isolation. And it leads to, we know that fat cells in the abdomen have 4 times the cortisol receptors as fat cells elsewhere. So when you're in this high cortisol state, like I was, and it sounds like you were, it just stimulates that belly fat because of the number of receptors. So that's just one example. But when you have high cortisol, it's kind of a bully. And it leads to these problems in the body. It robs you of progesterone. Progesterone is kind of like nature's Valium. It's this benzodiazepine that helps us feel calm and allows us to soothe ourselves. And so then you get an imbalance between estrogen and progesterone.
Could you talk a little bit about how estrogen and progesterone are sort of like agonist and antagonist to one another, or like two halves of a whole, and also how they shift throughout the course of the menstrual cycle, for example?
Absolutely. So I think of estrogen and progesterone kind of like tango partners, and you don't want one to dominate. So you want to have this really good balance between the two in order to have a good dance. So the menstrual cycle is confusing to everyone. We all learned it in biology in high school. The key part is that day 1 is the first day of bright red bleeding. So when you're still having your reproductive cycle, that's day 1. And what we know is that estrogen starts to climb around then. It reaches a peak around day 12. And then you have a surge in something called luteinizing hormone. I just want to footnote that for the future because LH, luteinizing hormone, can become a problem in people who restrict calories too much. So there's a nutrition connection to luteinizing hormone. But estrogen is the primary hormone of the first half of your menstrual cycle. The second half of your menstrual cycle is mostly the progesterone story. So that's where progesterone starts to climb. The way I think of it, beyond the tango partner analogy, is that estrogen is kind of like the bricks that get laid down in your uterus to create this wall. And progesterone is like the mortar that then comes between the bricks to stabilize things. And then you release the whole wall as your menstrual cycle, typically around day 28.
Thank you for that beautiful explanation and analogy. Very easy to follow along with. And I'm so glad you tied in the nutrition component because aren't our nutrients a part of literally everything? If we're deficient in key nutrients, it's going to impact our cycle. And not only when we're menstruating, but when we stop menstruating, we stop ovulating as we get into menopause. Before we talk about that, could you talk just briefly about what happens to estrogen and progesterone as we stop ovulating? What happens then? How do they get imbalanced?
Do you mean in women who are still reproductive age, or do you mean perimenopause? So both can cause ovulation to stop.
Yes, that's a great point. So what happens if you're not in perimenopause and something's going crazy? What happens before perimenopause or outside of perimenopause, before menopause?
So well before it, the most common reasons for not ovulating are polycystic ovary syndrome, which I see so much of. It's probably 20 to 30% of my medical practice.
Oh my gosh.
And it's often undiagnosed. So we know that about 70% of women are not diagnosed accurately. And so they're wandering around trying to figure out why they have so much weight loss resistance. And the root cause is polycystic ovary syndrome. So PCOS is one of those reasons for not ovulating. the underlying mechanism can get somewhat complicated. I'll try to keep it as simplified as possible without oversimplifying. But the
Thanks.
idea is that most of these women have insulin resistance. So insulin's not working the way that it should be. You have rising insulin levels. I think of insulin as being kind of this lock on the door of the cell that the insulin receptor is kind of waiting for insulin to come in as the key and unlock the door so that you can get glucose inside the cell. And unfortunately, that lock can get jammed where the cells become numb to insulin and insulin climbs higher and higher trying to fit that key in the lock. And you end up with insulin block or insulin resistance. So that's commonly the root cause. It then leads to other problems with growing visceral fat, leading to inflammation, leading to secretion of cytokines and these inflammatory markers. And it also can raise testosterone. It can do that directly through the ovary. And it can also do it indirectly by raising something called aromatase in the adrenals and then cause a problem, not just with testosterone, but also with estrogen. I'm making this a little more complicated, but it's actually a pretty
No,
complicated syndrome.
it's fascinating too because, and like you said, is if it's 70% of the cases are undiagnosed, I'm so grateful for you for taking the time to get into this a little because we have a diverse women audience listening, and I want them all to be they're going to all find something in this that's going to be super helpful. So I'm sure there are people who are really curious about this. So thank you for taking the time to explain it. Really helpful.
Well, I'm happy to go as deep as you want to on PCOS. I feel like it is the number one hormone disorder that I see. And it's not just a problem during reproductive years. It's also the number one driver of heart disease in women after menopause. So we need to pay more attention to it. But it's one of those reasons why you don't ovulate. So it can block
Yes.
ovulation. Another reason is nutrition. So for women who have weight loss, who say they go on a ketogenic diet and they restrict their total calories per day, that can, if you drop below a certain level, for me it's about 1,500 kilocalories, that can also lead to a problem with the LH, the luteinizing hormone,
Mhm.
and then you're not ovulating. So there's a lot of different reasons. Those are the key reasons before perimenopause.
And then when we are in perimenopause, which could happen at any range of ages, actually, we're starting to slow down. Our ovulation is starting to slow down. So our period's getting closer and closer together, and that's impacting our hormone cycles in our body. What's happening with estrogen and progesterone at that point, and how is that impacting us? And what other complications are there in perimenopause? I guess I'm so curious.
Well, let me say first, there's a lot of women who go through perimenopause and menopause and don't blink an eye. Like they have a great
Right.
experience. And I think those tend to be the women who have a great lifestyle, like they're very intentional and prepared. And then there's those of us who have a more rocky course. I feel like I've had pretty much every hormone imbalance that you can have to prepare me to have tremendous empathy for women who struggle with this and also to be able to talk about it with some experience.
Now, you just made a point before I just want to touch on. You said women who are really prepared going in. And I think that for women who have maybe aren't as prepared or have had to deal with other types of trauma or factors that have thrown their hormones out of balance, you can still garner a lot of resilience in your body by paying attention to your healthy lifestyle at any point in this course. And I think one of the big issues I hear from women is like, well, my workout's not working, or I'm not dieting enough, right? So that's why I'm so glad you're talking about this, because it is so important to continue to focus on what we call the 4 pillars of health: your sleep, your nutrition, your stress management, and regular consistent exercise. These things, it doesn't stop being important, right? It's still just as important for us, even though we might have a rockier time with our hormones.
Totally correct. And I think it's important to realize when you struggle with perimenopause or PCOS or any of these conditions that we're talking about, there's usually not a single answer. The
Right.
answer is this more global approach, which includes those four pillars that you're talking about, because all of those map to your hormonal function. So you asked about estrogen and progesterone, what's happening as you go through perimenopause. And what typically happens first is I think of perimenopause in two different phases. So the first phase is that you start to run out of ripe eggs and progesterone starts to decline. So a lot of women notice mood issues, they notice more PMS. In my case, I also had decreased libido. And then the second half of perimenopause is when estrogen starts to decline. And estrogen is complex. It's a little more complex than progesterone. It's a little more high maintenance. And it has about 400 jobs in the body. So, talking about symptoms, the list is kind of long. But in that first phase of perimenopause, when progesterone is starting to decline, estrogen can actually fluctuate wildly. And that's what triggers a lot of symptoms. It can trigger autoimmune symptoms. It can trigger, the mood changes, because some women are exquisitely sensitive to that estrogen signal. So that's a very tricky time. And then as estrogen declines, you start to get more of those symptoms that are more classically associated with menopause, like, noticing that your joints are not quite as lubricated and juicy as they used to be. More women have frozen shoulder. Your knees start to ache more when you're doing HIIT training. You may notice night sweats, hot flashes. You may notice that, you have anomia. You can't remember that word that's on the tip of your tongue. So those are some of the more classic symptoms that fit with the second phase of perimenopause.
And then, of course, isn't testosterone also being impacted as these other two get out of balance? And I think a lot about drive and muscle and all that stuff that we need from testosterone. But how does testosterone get affected when we're going through this?
I'm so glad you asked about testosterone, because it is now my absolute favorite hormone, because I think estrogen was like my favorite hormone for a while. And now I just feel like testosterone is so important. We're really realizing that it's kind of known as the sex drive hormone, but it's involved in so many more things than just sex drive and muscle making. It's a pleiotropic hormone. And a lot of people don't realize this. Here's a quick little truth bomb. For women, the most abundant hormone is testosterone. It's not estrogen, it is testosterone. And so it's the one that we are exquisitely sensitive to. So even though we have tenfold less compared to men, we are so sensitive to it. And when there starts to be some changes in testosterone, you really notice it. So what are some of those changes? Well, testosterone's involved in confidence, agency. It's also involved, it's an anabolic hormone. So it helps you build muscles, it helps you repair at night especially. And what folks don't understand is that when you start to have more mood changes, like, I mentioned with estrogen and progesterone, you can start to have more mood disorders, depression, anxiety, and so forth. You can also see that with testosterone, especially kind of a crisis of confidence and agency. That sense of your own power, your ability to, be fully in your power as you move through the world.
Mm-hmm. I'm so glad you're talking about this. And you also talked about repair of the muscle tissue. And earlier you mentioned human growth hormone. So we know one of the reasons sleep is our number one pillar of health is because, and exercise is the fourth. And some people are like, why isn't it the first? Well, because if you don't sleep, you can't actually get what you need out of those workouts. Tell us why that is.
Well, sleep, I would say, is as close to a panacea as we have in medicine. And you can't live without sleep. So I think it's important to put it first, because it is the foundation from which we design the rest of our lifestyle. So I think sleep is absolutely essential. It's more important than carbohydrates. That's like a whole other conversation. Carbs, yes or no, like what's your carb limit? We can live without carbs. We can't live without sleep. You will die without sleep. So sleep is really essential. It's what we know is that every hormone that I've talked about is released in a diurnal pattern. And
Right.
so, similar to a flower like a gazania that opens first thing in the morning and then closes near sunset, that's the way that most of our hormones are. Now, some of them,
Right.
like cortisol, you reach your peak cortisol first thing in the morning, usually within 30 to 60 minutes. And the anabolic hormones, such as growth hormone, that rises at night. That rises, the peak is usually 30 to 60 minutes after you go to bed.
It's so interesting because I think one of the classic symptoms of our day and age, especially during this time of COVID when everyone's stuck at home, stress is running higher, we're on our phones more often, we're getting so much more blue light exposure than we ever have as humans, which is completely disrupting our circadian rhythm, disrupting our body's ability to cycle down. Melatonin's not rising when it should. Cortisol's staying elevated. We're having all of this cocktail mix that's coming from actually our lifestyle, and maybe not even it, we're starting it, we're making it happen, and then we're dealing with the effects and not realizing that we could actually simplify and mitigate some of that stuff ourselves. Would you talk a little bit more about human growth hormone and why we want to get that good sleep? Because I'm so interested in that hormone as well as testosterone as well. I mean, I'm so interested in all of these hormones right now. I'm so grateful you're talking about them. I think we're all just fascinated, sitting on the edge of our seats.
Well, the way we think about it from a circadian perspective is that there's two quintessential hormones. So cortisol is the one that we've been talking about, which rises first thing in the morning and then it decreases before you go to bed. It's supposed to be at its lowest before you go to bed so that you're not all revved up when you're trying to fall asleep. And then the other hormone is melatonin, as you mentioned, which in some ways is the opposite. So it starts to rise usually 2 to 3 hours before you go to bed. And if you're blocking the rise of melatonin because of blue light, because of artificial light at night, you may not reach the peak that you're meant to reach. And so cortisol and melatonin are involved in this crosstalk, this dance with all of these other hormones, including insulin. So for instance, when melatonin rises, you become more insulin resistant. And so, 8 p.m. or 9 p.m., an hour before you go to bed, is the worst time to be eating a big meal and a lot of carbohydrates. Your most carb sensitive time is first thing in the morning. So you asked about growth hormone, which is possibly in a first place tie with testosterone for my favorite hormone, is so essential for many of the functions that we've already ascribed to some of these other hormones. It's an anabolic hormone, so it's involved in muscle repair and muscle building. And if you hear that and you think of bodybuilders, please don't, because all of us, you and I included, need to be preserving our muscle mass and maybe even growing it as we get older.
Yes, that's right. We talk about that a lot in this tribe of Betty Rockers.
I had a sense that was probably a topic of conversation. And I think the important piece to realize is that growth hormone and insulin are often at opposites, meaning that if you're someone who has an obesogenic lifestyle, so you're not sleeping, you're not hitting all those pillars that you just talked about, if you're eating too many carbs for you, if you're getting too much processed food or refined carbohydrates, or you have too much of that stress that we talked about, and insulin starts to rise and you have what's known as hyperinsulinemia, too much insulin to get glucose to go into cells, growth hormone tends to decline. And so, there's a number of ways that you can raise growth hormone with lifestyle, with food, with, different practices. Managing cortisol is another important piece here. And then you can also take growth hormone. I don't actually prescribe human growth hormone injections because of the controversy associated with it, but I do use peptides in my practice. And I find for women over the age of 35 and 40, that can really make a big difference in terms of, that fat gain that we tend to have after the age of 35 and 40.
Right, because of course, when we carry muscle, we're able to burn more when we're eating. We're able to store more glycogen. We're stronger. And what's the correlation with our testosterone? Because you said these two are your two favorites. I'd love for you to talk more about testosterone because it's just also, I think, probably one of my favorites right now, just because of where I'm at in my life and what I'm trying to accomplish. And I need it. I need it to be functioning. It's like I want to drive a V8 with an, I don't want to drive a 4-cylinder engine. I need a V8. So,
Well, yeah, I think we all want to have that capacity to sort of drive the V8 when we want to, because there's times in life when we need it. And then there's other times
right.
where it might make sense to drive a Prius. And I think
Right. So I have 2 cars. 2 cars is good.
yeah, we want choices. Women need
Right.
choices.
Women need choices.
So testosterone is super interesting. I just did a huge talk on cardiovascular disease in women. And what we know is that testosterone is also involved in your risk of cardiovascular disease. And I mention this because heart disease, cardiovascular disease, is the number one killer of women. It's the number one killer of men. We need to care more about this. Even though we tend to care about breast cancer and we tend to care about Alzheimer's disease, we have to care about heart disease. And we know that women who have a problem with testosterone, so either it's too high, like we see with polycystic ovary syndrome, most but not all, and also when it's too low, you're not going to get the support that you need. So
Right.
ideally, with all of these hormones, you want to be in that Goldilocks position where it's not too high.
I was just
not too low.
thinking that. Right. Goldilocks. It's the Goldilocks, right? Just got to have it just right. I know we want to move on to talk a little bit about menopause and how some of these hormones are impacted in that stage of our life. I'm just so curious because so many of the women who write me don't realize that the symptoms that they're experiencing have to do with their hormones. And I'm really hoping that after we talk today, some of this stuff will really start to become abundantly clear. But is it your experience that a lot of the time our symptoms that we're feeling in, say, our 30s and maybe 40s, and we're not at menopause yet, are just chalked up to aging and sort of the common talk about this, even with doctors generally, and that it's not so much to do with it's your hormones, you're a woman, you're very finely, sensitively tuned dials. Let's go check that out. I just wonder if that's what your experience is, where a lot of women have been dismissed and that it's about aging or whatever.
Definitely women are getting dismissed right and left when it comes to hormonal changes, and no one bothers to check their hormones. So this makes me, crazy. And I feel like what I was taught when I went through my medical training, and I feel really blessed by the type of training that I had. I don't mean to dismiss or minimize it in any way, but what's amazing to me, Bree, is that when a woman's trying to get pregnant, we will check every hormone. There's like no stone left unturned. We'll check thyroid. We'll go way beyond just the TSH. We'll look at free T4, free T3. We'll look at FSH, estradiol. We'll look at cortisol. We'll look at testosterone. We'll do all of these hormone testings. But if you take a woman who's the same age, let's just say she's 35 or 32, and she goes to her doctor and she's not trying to get pregnant, and she says, I'm exhausted. I don't have the energy that I used to have. I have all this belly fat accumulating, and I haven't changed what I'm eating. I'm still running, and yet I feel so depleted. What can we do? Can we check my hormones? That person is told, we don't check hormones. We think they fluctuate too much. It's not worth checking them. And that's what we need to change, because we can't have a double standard. What's helpful in terms of understanding why a woman can't get pregnant is also helpful for the woman who's not trying to get pregnant.
Yes, I'm so grateful that you are talking about this. And I'm so grateful that you, the listener, are listening to this, because we have to be our own advocate sometimes. And so I wanted to just say that these symptoms that you're experiencing, if you're practicing your 4 pillars, you go, girl, you keep doing that. And there are other things that you can also get checked out, just like Dr. Gottfried is talking about. So thank you for speaking to that, because I just feel like so often we doubt ourselves and we want our doctor to be the expert and to know. And I think we just need sometimes to talk to a doctor who does care about our hormones specifically. And that's what I want you to look for out there?
Well, this is a really important piece because, what I found is that unless you have a doctor who has some personal experience with their own hormonal imbalance, they're not thinking about, dysregulation of the HPA. They're not thinking
Right.
about, okay, what role is cortisol playing? What role is trauma playing in terms of the energy that you feel today or whether you're depleted or not? And some of these hormones, we talked about estrogen and progesterone and how it starts to change around 35 to 45, but some of these hormones can change in your 20s, and that includes the androgens. So the androgen family is not just testosterone, it's also DHEA.
DHEA.
You measure it
Yep.
as DHEAS in the blood. And what I find, especially for women who are stressed, especially for women who have that toxic stress of adverse childhood experiences, they start to deplete their DHEA and their testosterone usually in their 20s. So it starts to decline about 1% per year at some point in your 20s, and that gets accelerated if you are chronically stressed.
It's accelerated if you're chronically doing cocaine, abusing recreational drugs, smoking, all the things I'll say that I was doing at the time to deal with the pain that I didn't know I was trying to suppress. I was chronically abusing alcohol. All these things you try to do to escape the pain that you're feeling. This stuff exacerbates the hormone cocktail that's should be perfectly mixed, shaken, not stirred.
It definitely does. Can we talk about alcohol for a minute? Because
Please, I'd so love for you to talk about how that affects us. Thank you.
well, alcohol, my particular stand is not wildly popular. But
Let's hear it.
we'll just start with the facts. So the facts are the very thing that I think many of us turn to alcohol for, which is, like relief, like peace, and trying to just, phase change what we're feeling. Like you feel that sense of stress. It's 5 p.m. I want a glass of wine. I want a cocktail. The very thing that you're hoping to get from the alcohol, it's actually going to rob from you.
Right.
So we know
That's
that
the great
alcohol
irony.
raises your cortisol level. It raises your cortisol, for some period of time. So that next morning, your cortisol is going to be higher. And then over the long term, it tends to raise your estrogen levels to a point where there's a greater risk of breast cancer. So as little as 3 servings per week of alcohol is associated with a modest increased risk of breast cancer. And the risk is much higher above 3 servings per week.
And what does it do to testosterone? Doesn't it lower our testosterone after we've had alcohol?
Most of the data shows that it does lower it. I've seen mixed data when it comes to DHEA and testosterone. It's certainly not something that I would drink to try to modulate testosterone because there's much better ways to do that. So I would say the data is
No,
more mixed.
I just meant from a negative perspective, I guess I was thinking of how that would suppress testosterone that's part of, I was just thinking about the hangover effects and some of the hormones that are impacted the next day, how it affects, why is it that we reach for more sugar, for example, because it affects our insulin response. It affects our ghrelin and leptin, correct?
That's absolutely right. So I think of the effect on insulin as being really important. We know that one night of bad sleep makes you more insulin resistant the next day. We know that higher cortisol is going to disrupt the regular insulin signal. And if you are chronically disrupting it by drinking, a moderate to heavy amount, that's going to lead to more insulin resistance. When you put that together with other choices like high stress, like not getting adequate exercise, not making your muscles hungry for glucose, that's where you start to get this compounded interest of problems with insulin resistance.
And I was really intrigued by how you talked about human growth hormone and insulin as being two. Also, they're also doing a tango, and it's interesting because if human growth hormone is at its peak when we're sleeping, if we're interfering with our ability to get a good night's sleep by eating sugar late at night or drinking alcohol at night, which is usually when we drink alcohol, wouldn't that also impact human growth hormone and its ability to be effective for us?
Yes, I can't, I always try to think of what does the literature tell us? And I
Sure.
don't have the
I'm
data
making some
off the top
broad
of my head.
generalizations, just guessing.
I think it probably does. I mean, there's a number of things. We know that stress decreases growth hormone. And so, when I was thinking this through and loved a glass of wine back in my 30s and 40s, the way I would approach it is, well, I'm going to have a glass of wine at lunch. It's not going to disrupt my sleep. But that's not the answer either, because then it ties up your liver with detoxification, and that's not necessarily the answer.
I'll tell you the approach I've come to at this point. And there were years I just, I had to find my peace with, and alcohol wasn't really the problem. I had a lot of problems I needed to root out at the very root in order to deal with all of the addictive type of behavior I was exhibiting. But I actually, I own a vineyard in upstate New York with my two brothers. And I also am a huge supporter, and I love dry farm wines because they're very low in sugar, and low in alcohol particularly. And so on the days that I do choose to have a glass of wine, it's only something that's very low in alcohol and low to no sugar wine, just because I can enjoy it without feeling off. I get a great night's sleep. It doesn't impact me. But I've really started to be super sensitive to how do I feel as I pick up this glass of alcohol? How is my body responding? And there's sometimes I smell it and taste it and it feels like poison to me. And I just put it down and I don't have it. And there are other times it's like, oh, this is great. And I bet you anything it has something to do with where I'm at in my cycle and how rested and recovered I am as to when my body's going to be receptive to that. That's just my intuition. But I like my intuition. It's really smart. So I listen to it.
Well, there's a lot of science behind what you just described, Bree. And I think this is important to highlight because we know that you are your own best doctor. If you look at how much time you spend in a physician's office or another, healthcare professional, it ends up being about 1% of your health, whereas the other 99% is having that level of intuition, discernment, being able to tune into what's true for you. And I think that is really the foundation of health. So I love what you just described, which if I put my nerd hat on, I think I've had it on for a while.
I'm such a nerd fan.
So
fellow nerd.
we call that interoception, kind of this ability to really tune into what's true for you and to be able to read your body. There's some women who are listening to this, and this was the case for me back in my 30s, who could have a glass of wine and not really be able to discern whether it's what their body wants or not. So I would say that's kind of a higher order place to get to that I hope more of us can get to. And we need to be able to develop that sense of discernment to really figure out, okay, what's the best choice for me? So it might be dry farm wine. It might be that some of our listeners have a sticky relationship with alcohol and it's easier to just abstain.
Just abstain. And I would be an absolute supporter of that because there were years of my life I did not have an easy time making those decisions. And I wasn't able to be discerning in this case or have any control over it. Now it's not about control. It's about choices. And that's, I've had the opportunity to do some really deep work on myself and continue to do that work. So there are stages that we go through in life as we're talking about here. It's very, very important. Thank you for taking that detour with me about alcohol. I'm so glad we talked about that because as women, we're just trying a lot of the times to get through the day and trying to feel okay. We're asked to do so many things. Women are all superheroes. We've got so many responsibilities. We're showing up in the best way that we can. We're powerful. And yet there's always so many decisions to be made. And sometimes it feels like I need a cookie or I need a glass of wine or I need that reward at the end of the day. And I've loved in reading your books how much you've embraced yoga, how much you've embraced practices that help lower your stress and really deal with that cortisol impact. And I wonder if you would speak to some of the things that help us mitigate the cortisol impact and sugar impact, because those practices are really amazing.
They are amazing. And what I like to have my patients do is to come up with an a la carte menu of their favorite ways to mitigate stress. Because I do have some patients who come to me and they say, listen, Dr. Sara, I know you're a yoga teacher. I know you're really into meditation. There's just no way that that's ever going to happen. So there's lots of ways that you can buffer the effects of toxic stress. So one is orgasm and sex. That's one of my favorite ways. Another is with your food choices. So, there's stress that's caused by food, especially if you're someone like me who's a bit of a cortisol junkie. We know the high cortisol can cause increased intestinal permeability, known colloquially as leaky gut. And then that can lead to a greater risk of food intolerances and dysbiosis. So, staying away, testing yourself if that's available to you, or doing an elimination provocation diet is a great way to check that out. Another piece that I think is important is finding some way to objectively look at your life. And so that could be meditation for some people. It could be mindfulness-based training for other folks. It could be psychedelic-assisted psychotherapy. That's increasing in terms of the effect that it has on post-traumatic stress disorder and also on recovering trauma. And the effect sizes are enormous. And I'm talking here about, the medications that are the most studied and probably are going to get approved for this include MDMA and ketamine. So I'm not saying, everyone who's got cortisol problems needs to rush to a psychiatrist's office and demand.
You're talking about our a la carte menu. There are
It's
many
an a la
choices
carte
on
menu.
it.
For some people it's vacation. For some people it's a walk with the dog. For some people it's, just some way to kind of get a little distance from the drama and the vicissitudes of life that are happening and unfolding right in front of us.
Oh, that's really helpful. Do you mind if I bring us back to menopause? Because
Yeah.
this is, for me, the next frontier, of course. I'm super interested in what happens to our hormones around menopause. What's happening to my women who are writing me, asking about it, and what can they do about it?
Well, with menopause is officially just one day. It's the one day that you are a full year without a period. And I still haven't hit menopause. I'm like eagerly awaiting. I'm going to have the biggest party, Bree.
Good, because it's such a rite of passage for us, right? It's a transition.
It's a rite of passage. In fact, there's this tribe in Africa where menopause is revered, and menopausal women train the younger men in the tribe in sexual ways. So I think we need to flip sort of our approach to menopause. And I very much look forward to not having to use tampons and pads once a month. But here's what's happening hormonally. You go through that second phase of perimenopause. You've got decreased estrogen, decreased progesterone, and then you go a full year without a period. And some women sputter, as you described. They may go 2 months without a period, and then they have one. There can be, some heavier bleeding that can happen. You may want to see your gynecologist for that. If you have a cycle that's more often than every 21 days, that would be a reason to go see a gynecologist. But when you're in menopause, your estrogen's low, your progesterone's low, you can still have estrogen dominance. So you can have low estrogen and super low progesterone and still have, not have a good tango between them. And this is a time where testosterone continues to decline. And so a lot of women notice that their thyroid doesn't work as well. They can go through thyropause. We haven't talked much about the thyroid. And testosterone has its hands in so many different things that we know starting around between age 40 and 50, on average, we're losing 5 pounds of muscle mass and we're gaining 5 pounds of fat mass. And so testosterone and growth hormone are definitely involved in that process. Blood sugar tends to climb. And the more insulin resistance that you have, insulin block, the more likely you are to have vasomotor symptoms. So that's the hot flashes, night sweats, difficulty sleeping.
So this is all really helpful from understanding how it all works, right? It's so helpful because I think just what we were talking about before, women being dismissed for their symptoms, and then us being more proactive and empowered by the knowledge of like, okay, here's what's happening in my body. Here are some of the signs and symptoms. It's not me being crazy. It's not me not exercising enough, or, I need to stop eating, all of these things that we know are wrong for us. Instead, it's something going on inside of that, what I call the symphony, or you call the symphony. We all call the symphony of the hormones, because they need to be in a harmony in order to work correctly for us. So I think the biggest question of all is, what do we do about it?
Well, that's the biggest question. So I have a lot of patients who come to me and they're experiencing some of these symptoms, whether it's the fat gain and the muscle loss, or it's the vasomotor symptoms, or they haven't slept in a year, or they've got mood issues. And so they often will ask, am I a candidate for bioidentical hormone therapy? So that's a complex decision. I think it has to be personalized for each woman. In general, I'm a fan of bioidentical hormones, although I have a lighter touch than a lot of other clinicians. So there's some folks who go through like a weekend training in bioidentical hormones and then hang a shingle, and I'm really cautious about those people. So what I often do is sit down with a woman and really understand, okay, here's your genetics and what we know in terms of your increased risk: cardiovascular disease, breast cancer, stroke, Alzheimer's disease, et cetera. Here's your biomarkers and what we know about your insulin and your growth hormone and your estrogen and progesterone, and what we can do about it. And here's some of the options. And I like to go to lifestyle first, because there's things you can do just with your food to modulate some of these hormones. Exercise too. For a woman who's really suffering, most of the time I find that lifestyle is not necessarily the first step. Often we have to jump to bioidentical hormones and then, kind of dial in the lifestyle changes as she starts to feel better. Because if you're having night sweats and hot flashes and you can't sleep at night, like no amount of HIIT training is going to be helpful.
And really, it's going to be damaging to you because you're exhausted and you're just making yourself even more tired.
And you can't recover. So
you can't recover. So yeah.
So it's a delicate process. In general, I think women are undertreated right now for perimenopause and menopause. We swung too far in the opposite direction after the Women's Health Initiative was published. Right now, only about 5% of menopausal women are getting treated with hormone therapy, and I think that's just way too low. So we need to find that middle ground where more women are getting access to treatment. It's also not a yes or no answer. I think it's really important to realize that you could do a half dose. You could do 3/4 dose. We could do pulsing, where we give it to you for 3 months and then you come off of it and we see what happens.
That's what you're saying. It's highly individualized, and the woman, you working as a doctor and a patient relationship needs to be an intimate relationship where you really get to know like you said, the holistic health history of your patient, not just their genetics, but also their lifestyle, all of their everything that's going on.
And their values. I think values are incredibly important too. There's some women who will say, listen, my belly fat doesn't bother me. Like, what bothers me is my sex drive. Like, let's focus on that. And then I have the other woman who will say, help me lose 10 pounds of fat, and then we'll focus on the sex drive. So I think values are really important here too.
Right. Highly individualized, each person and her needs. It's got to be and done in practice, basically. And I think my point that I was trying to get at is, we need to understand what's going on with our bodies. We need to be able to advocate for what we need with our healthcare, and we need to seek out practitioners who are truly practicing the medicine that we need at this time in our lives. So I want to recommend everybody read Dr. Gottfried's books, which I have read extensively. I love your I love all your books, but what would you tell people to start with? What's the first book they should read?
I would say The Hormone Cure. I think that's the foundation for really understanding all the other books. So, that's where I went through the top 7 hormone imbalances that I see in my practice. It's got a questionnaire
It's got the quiz. I love the quiz. It's so good.
it's got the
And I got a
quiz.
lot of custom supplement recommendations from your book that I think have helped my energy a ton. So I really appreciate that quiz, and I really recommend that.
Thank you. I'm so glad it's helped you. It's what I wanted to do was to take what happens behind closed doors with seeing me as a patient and making it available at the lowest possible price point.
That's just truly amazing. And you've done that. I mean, I felt like I said, I feel like I've gotten to know you through watching your stuff on Instagram and being connected to you on social media, but also reading your books. And I know that all of you listening will go look up Sara's Instagram and follow her and connect with her on social media. But she also has a fabulous website. I've done your 10-day course. Actually, I don't think I told you that. Absolutely loved it.
Fantastic.
Learned so much. Really, I just wanted to take the book a step further, so I really enjoyed that. So there's just a wealth of information that you can get from Sara, and as you go through her material, you can see what sparks your interest and what stands out from you guys from the quiz, like it did for me, and how it can help you start the process. I still think we all need to see a doctor if we're dealing with these things, and I'm sure that it's just a good place to start. And I know that you're planning to open your practice up again at some point, so that's very exciting too. What are some of the best ways people should connect with you?
I'd say the best place is my website, which is saragottfriedmd.com. And if you want to learn more about becoming a patient, I'm going to be doing telemedicine starting a little later on this year. That's saragottfriedmd.com/patient.
Amazing resources, because I know so many of my listeners would love to probably follow up and become a patient potentially if their state allows that. So thank you for sharing that. And I really want to give you the last word here. Is there anything else that you'd like to say to the audience, anything that you'd like to talk about that we haven't addressed yet? No rush on that.
I'd like to circle back to a point that you made about being dismissed. So
thank you.
I feel like I was dismissed. That story I told you at age 35, with the whiteboard, exercise more, eat less. And this is one of those places where we really need to stand in our power. And we need to change the conversation about hormones and getting stronger and have more agency as we get older. And so if you have a clinician, if you have a doctor who's dismissing you, I hope that you feel galvanized from this conversation to fight back, to advocate for yourself as you described, Bree, and to say, this is not just me getting older. There's something going on. I want it investigated. And if you don't have a collaborative clinician, get a new one.
That's right. You've got a lot of choices. And we're women. We like to have choices. We need to have choices. So take advantage of all of the choice that you have and find the person who is right for you. And don't stop looking until you do. It's your life after all, isn't it?
Yes, it is.
Man, I so appreciate the opportunity to having this conversation with you. I feel like I could talk about these things with you for many more hours. And I hope that we can have you back at some point and do a follow-up, because I'm sure we'll get a lot of questions from our listeners about this show. Thank you again so much for being with me, Dr. Gottfried, and I look forward to connecting with you again.
My pleasure, Bree. Thank you so much. And thanks to all of our listeners.
As Dr. Gottfried said, thank you for listening so much. I hope you got some great insights. And remember, you can find all the links to everything we mentioned in this episode over on thebettyrocker.com/podcast. Share this episode with your friends and the women in your life you care about. We're all in this together, and we really need to support each other and share good information and resources. I appreciate you for spending time with me today. And I'm excited to continue this exploration of our hormones in next week's conversation with hormone expert Dr. Jolene Brighton, author of Beyond the Pill, who will add some new angles to this conversation and really help you watch out for yourself. So stay tuned for that, and know how deeply grateful I am for all of the amazing reviews on iTunes and the podcast players you're listening on. taking a minute after listening and sharing your feedback on these episodes is very meaningful to me, and I am so glad this podcast is providing value to you. So until next time, remember, I'm Betty Rocker, and you are so awesome and amazing. I'll talk to you real soon.
This podcast is for information purposes only. Statements and views expressed on this podcast are not medical advice. This podcast, including Brie Singer, Betty Rocker Inc., and the producers disclaim responsibility for any possible adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for statements made by guests. This podcast does not make any representations or warranties about guest qualifications or credibility. Individuals on this podcast may have a direct or indirect financial interest in products or services referred to herein. Before starting a new exercise, fitness, or health protocol, or if you think you have a medical problem, always consult a licensed physician.